Thank you, sir. So I'll be talking on subarachnoid hemorrhage. Although it accounts for nearly 2 to 5% of all stroke patients, but it is often a devastating event as we all know, and it is associated with significant morbidity and mortality. The important thing here to understand is if it is timely diagnosed and treated within a specified period of time, this mortality and morbidity can be reduced. So 12% of patients, they die even before reaching hospital because the symptoms are often subtle. They may present with just headache and they may not report to the hospital. So diagnosis is delayed. 25% die in the hospital because of the unavailability of expertise and the complications associated with SAH. And out of those who present to the hospital, 50% of survivors are left with lifelong significant deficits. So why the high morbidity and mortality with SAH? As I said, because of the delayed and missed diagnosis, the expertise, the imaging may not be available at the hospital, so there is delayed diagnosis, there may be delayed repair and there may be rebleeding so that this worsens the prognosis. Even if it is repaired on time, because of the complications associated with it, it may lead to again a high mortality. And last but not the least, we all deal with these infections which are associated with prolonged ICU stay may lead to the morbidity. So let's start with the case of 55 years old gentleman, smoker, diabetic and hypertensive, suddenly complains of extremely severe headache and they characterize it as worst headache of their life. It is associated with nausea and vomiting and there is a brief period of loss of consciousness. On arrival to the ER, he is opening on eyes on verbal commands, he appears oriented and he is moving all four limbs on verbal commands. He gives a history of 2 to 3 times of headache over the last 1 week. Heart rate is okay, BP is 180 by 80, respiratory rate is within range and the RPS is 210 gram percentage. So how do we proceed from here? We all know we deal with such sick patients. The ABC is of paramount importance. Since the patient has got a GCS of 14, patient is opening eyes on commands, moving all four limbs, appears oriented. So patient's airway appears to be protected, so he doesn't require any airway protection as of now. Vitals were within acceptable range except a bit of hypertension and blood sugar levels were high, so glycemic control has to be achieved. So, are there any risk factors for SAH or do these symptoms correlate with SAH? Yes, the symptoms here are consistent with SAH because patient has presented with worst headache of his life. So, most of the patients, the most common symptom is sudden severe headache and they have not experienced such severe headache in their lifetime. They also characterize it as thunderclap headache because there is abrupt onset, the peak is reached within minutes and then it comes down and it may be associated with other neurological symptoms like nausea, vomiting, photophobia is common in such patients and there may be altered level of consciousness. Risk factors, smoking and hypertension, they account for majority or the strongest risk factors for the SAH, and the patients who are smokers as well as those who have history of hypertension, they appear to be more prone for SAH as compared to other risk factors. Female preponderance has been seen, though it is unexplained why, probably because of estrogen deficiency. That is why it is seen in females of elderly age group. Alcohol abuse, other genetic disorders like polycystic kidney disease, Ehlers-Danlos syndrome, these are not uncommon to find in SAH patients. Apart from this, drugs like cocaine, amphetamines, those abusers are also prone for SAH, and we all know that the first degree relatives of SAH patients are also prone. So any patient who is diagnosed with SAH, their family members should also be screened for aneurysmal the SAH. Premonitory signs may be present in some of the patients. There may be sentinel headache because of a small leak or small bleed in the patients and which may be present within weeks of SAH. So any patient giving history of recurrent severe headache and they present to you with unconsciousness, probably the patient has got SAH. Common site of rupture, Distal ICA and its posterior communicating artery junction is the commonest, followed by anterior communicating artery or anterior cerebral artery. So these areas are common sites for aneurysmal SAH, followed by middle cerebral artery and then the posterior circulation. So how do we investigate further? We have a patient who has signs or symptoms suggestive of SAH. Then how do we want to investigate? The investigation or the imaging of choice is non-contrast CT head, because to diagnose any bleed, non-contrast CT is the preferred modality, and it has been seen that it is nearly 100% sensitive if it is done within 6 to 12 hours of onset of symptoms. However, the sensitivity goes down with the passing days, and it is roughly 85% by day 8. So patients who are presenting late to us may have a normal CT. So it is 99 sensitivity within first 24 hours. And how does blood appear? We know that it is a high attenuating amorphous substance that feels normally dark, sulci and gari or the arachnoid spaces in the brain. So there is white appearance in such black normal spaces, and the common sites are the basal cistern, sylvian fissure, interhemispheric fissure, and it may be associated with intraventricular hemorrhage also. So this is the CT scan of our patient. You can see all white areas which are involving the cisterns and the sulci gari of the patient. So blood is present in the interhemispheric fissure, which is denoted by this red arrow. It is also present in the right sylvian fissure, and there is blood in the lateral and the third ventricles also. So as I have said, sometimes you may get no evidence of bleed in the CT scan, but still there is high suspicion of SAH. Then what are you supposed to do? Sorry? No. So those presenting late may have got a normal CT scan, but if you have got high suspicion of SAH, you will go for lumbar puncture to look for xanthochromia. A negative CT head and lumbar puncture, both negative, effectively rules out the diagnosis of SAH as long as both tests are performed within a few days of the event. So what are the findings on lumbar puncture? Because of the blood in the subarachnoid space, there would be elevated opening pressure. The tap which you will get will appear pinkish or yellowish. We call it xanthochromia. However, a traumatic tap may also give a picture similar to xanthochromia. So how do you differentiate, how do you rule out traumatic trap from this xanthochromia? You take the tab and sample in the 4 bottles, and then you compare the gradient of red blood cells in the samples. Traumatic tab, the red blood cells would be predominant in the first sample, and then the concentration will go down with the further bottles. But if it remains same in all the 4 bottles, that means it could be blood in the subarachnoid space, that is xanthochromia. However, to effectively rule out, the last bottle should be normal. So significance of xanthochromia, when will you call the CSF as xanthochromia? It is pink or yellowish tint. It is present because of hemoglobin degradation products, and for that blood has to be present in the CF for at least 2 hours. If you do lumbar puncture before 2 hours, you may get a normal tap. So it has to be there for at least 2 hours to have to present it as xanthochromia, and it lasts for 2 weeks or more. So if patient present to you late, but after 2 days, after 2 hours or within few weeks of the presentation, you may still get xanthochromia in such patients. However, xanthochromia, there are certain conditions which mimic xanthochromia. One is elevated CSF protein. So if the protein concentration is more than 150 milligram per deciliter, you may get a similar yellowish pink tint of the CSF. Systemic hyperbilirubinemia, where the bilirubin levels are more than 10 to 15 milligram per deciliter, and obviously traumatic tap with a high concentration of RBC will also give you a similar picture. So you have to rule out these conditions before calling it as xanthochromia. So there has to be a high level of suspicion on clinical basis, and then the imaging and the other investigations correlate with it. Detecting by comparing a vial of CSF with the plain water side by side against a background in a bright light will give you an idea whether it is a xanthochromia or a normal CSF. Other investigations, if you have still doubts, you may go for MRI truncated images, flare, DWI, which can be done in such patients to diagnose or to rule out SAH. They may be useful, but again, if you have got a normal MRI scan, that does not rule out SAH. You will still have to perform lumbar puncture before completely ruling out the diagnosis. Now, what is the next step? Once we have confirmed our diagnosis that patient has got SAH, we would like to find out the etiology. SAH mostly are spontaneous, which could be because of the aneurysmal rupture or it may be traumatic. Traumatic, you just have to manage as per the protocols, but aneurysmal SAH has to be diagnosed timely so that you can obliterate the aneurysm and prevent further complications and rebleeding. So spontaneous SAH, most common causes are cerebral aneurysm followed by AV malformations. These two causes account for majority of cases of spontaneous SAH, and the other uncommon causes are angiomas, vasculitis, arterial dissections, which are rare to find in such patients. So once diagnosis is confirmed, you would want to find out the cause of the bleeding, and the gold standard test for detection of aneurysm is digital subtraction angiography or DSA, which is only done if the expertise is present in the hospital, and in the peripheries where the intervention neurologist is not there or DSA is not possible, then you may like to go for CT angiography or MR angiography, which detects a little larger size aneurysm. It may not pick up the smaller aneurysm, but still the sensitivity of picking larger aneurysm is around 90%. So if you don't have that expertise, at least go for CT angiography and MR angiography. At least you will get to know it is aneurysmal HAS. You can manage as per the medical management, and you can transfer the patient to the higher specialties. Risk factor for aneurysmal rupture. Aneurysm of size more than 7 mm are more prone for rupture. So even if patient presents to you with headache and you perform CT angio or MR angio and patient has got large aneurysm, it has not ruptured yet, it is better to refer to a higher center where DSA can be performed, and that bleed can be prevented by performing the procedure on time. And obviously, bottleneck aneurysm, the ratio of aneurysm to parent size vessel is large. That means such aneurysm are prone for rupture. So, are there any severity gradings available? Commonly, it is usually asked in these exams, and there are two clinical severity which are available and commonly asked. One is the Hunt and Hess scale, and the other is the World Federation of Neurosurgical Societies scale. And this survival is inversely proportional to the grade. If the patient has got severe grade, the chances of survival of such patient decreases. So it helps you to prognosticate the patient, it helps you to monitor your treatment, and such patients may require strict monitoring and the intense management. Hunt and Hess, just to revise, the grade 1, the patients are asymptomatic or they have got just complaint of mild headache. Talking about grade 2, the severity of the headache increases, there is nuchal rigidity, but there is no focal neurological deficit. When we talk about grade 3, there is mild focal deficit and patients may start becoming drowsy or confused. Grade 4, the patients are stuporous and there is moderate to severe heavy paresis. And talking about grade 5, the patients are deeply comatose and they may have decerebrate rigidity. The other scale, the clinical grading is WFNSS. The grade 1, it is based on the Glasgow Coma scale. Grade 1, the patients have got GCS of 15 by 15. Grade 2, patient have got 13 to 14 GCS but without any motor deficit. Once there is motor deficit, the grading comes out to be 3. And grade 4, the GCS goes down to from 13 to 14 to 7 to 12, and grade 5 is GCS less than 7. Management are routine basic critical care management. Airway has to be secured. Patient may require intubation if the GCS is less than 8. Again, hemodynamic and neurological monitoring. The BP has to be controlled. There are certain cutoff which has to be maintained. Fluid management, historically it used to be hypervolemia to prevent the vasospasm, but now the guidelines say that you have to maintain euvolemia as in other neurological diseases, isotonic fluids have to be used. Do not use hypotonic fluids. There may be ECG changes like ST depression, QT prolongation. You may suspect that patient has got ACS, but these findings are common in conjunction with SAH and they revert back within weeks of treatment. You have to make your patients comfortable. Analgesia is so that you can prevent intracranial hypertension, stress ulcer prophylaxis, and you have to treat fever and sugars strictly so that you don't injure your patient more. Now talking about blood pressure control, until the definitive management, which is clipping or coiling, systolic blood pressure should be kept below 160 millimeter of mercury. And you give, I'll be talking about this, you give nimodipine to such patients, you give analgesia, that takes care of the blood pressure to a certain extent. But if it is not controlled by these measures, you may have to use antihypertensive agents in terms like labetalol or nicardipine. If systolic blood pressure remains high despite these treatments, you have to further lower the blood pressure, but you don't have to just come down on the BP suddenly, because that may reduce your cerebral perfusion pressure, which has to be maintained above 70. So a higher blood pressure so that you don't reduce the cerebral perfusion pressure much. And reduction has to be based on the neurological status. If you start reducing the BP and you see your patient is becoming neurologically worse, that means you are hampering its perfusion pressure, then you may have to target your blood pressure at a certain higher level. So it has to be continuous monitoring and continuous titration of blood pressure. Thromboprophylaxis is must like any other ICU patients. Mechanical thromboprophylaxis has to be provided by compression stockings or pneumatic devices. And if your patient is prone for DVT, it's a high risk patient for DVT, then you may have to give low molecular weight heparin, but it should not be given before 12 hours of clipping or just immediately after coiling. Definitive management, though we should know about it, but that's the part of neurointervention or the neurosurgeon. Surgical clipping or endovascular coiling. These are the two options which are available for aneurysmal SAH patients. Again, if patient has got AV malformation, you may resect or you may embolize. Again, endovascular versus surgical option. But it has to be performed as early as possible. The main reason behind it is to prevent rebleeding, which may further worsen your prognosis. Whether to go for endovascular coiling or the surgical option, it depends upon the patient's age, comorbidities and location where the aneurysm is present. Endovascular coiling, because it's a minimally invasive procedure as compared to the surgeries. Elderly patients who have got many comorbidities, bad patients, we should go for endovascular coiling in such patients. And patients where the location is difficult and the surgical option may not be followed. So such is, for example, the posterior circulation or the base of the skull aneurysm, endovascular coiling is preferred as compared to the surgical clipping. Surgical clipping, where there is wide neck, you can easily clip the vessel. Where there is large hematoma, there is mass effect, you can simultaneously decompress that area, you can remove the blood clot. So when such kind of presentation is there, the intervention neurologist would prefer to go for the surgical clipping as compared to the endovascular coiling. So if you have got, if patient fits into endovascular coiling and expertise is there, it should be done as early as possible. If it is not there and surgeons are there, then surgical clipping should be done, whether the patient fits the criteria of endovascular coiling. So early intervention to reduce the rate of bleeding, that is the most important priority. Complete obliteration is recommended whenever possible. And in patients with ruptured aneurysm, which are amenable both to coiling and clipping, and you have intervention neurologist in your hospital, coiling should be preferred because it is associated with lower morbidity. Now, what complications are expected during course? This is important because mostly the patients come to ER, it is diagnosed with aneurysmal SAH. In the emergency, patient goes directly to the cath lab, the coiling is done, and now the patient comes to you, and here where your role comes. We should know what are the known complications and which we have to timely diagnose and manage. The most common is the rebleeding. It is a preventable complication and it reduces the morbidity and the mortality of such patients. The second common complication is hydrocephalus, which can also be treated if picked up on time. Vasospasm, delayed cerebral ischemia, because it develops after certain days and the risk lasts for a few weeks. So this troubles us much. Hyponatremia, seizures and other cardiopulmonary complications are also associated, and we should also these things in mind. Talking about rebleeding, early rebleeding is very common. Nearly 20% happens in first 24 to 48 hours, and as the time passes, the incidence of bleeding goes down, and it is highest in the first 12 to 12 hours. Then sometimes you get the patient who had SAH and peripheries, and till the time the patient comes to you, patient has rebled, and then the prognosis goes down. It appears as acute deterioration in GCS, and when you repeat the CT scan, you find new hemorrhages on the scan. And the risk factors: longer time to aneurysmal repair, higher severity of SAH, initial loss of consciousness, larger size, and the most important and the preventable is the higher systolic blood pressure, which has to be kept below 160 millimeter of mercury. So it is the most common cause of early death along with ventricular arrhythmia, and there is worsening in the prognosis if it has happened. So how to prevent early aneurysmal control is critical. Target systolic blood pressure less than 160 or MAP less than 110, and it has been started that a short course of antifibrinolytic like tranexamic acid, if it is initiated after the radiological diagnosis and it has to be stopped within 24 to 72 hours, it has seen to reduce the rate of bleeding. So again, same thing, either epsilon aminocaproic acid or tranexamic acid, whatever is available in your hospital, if it is given within 24 to 72 hours of event, can reduce the chances of rebleeding. Second complication is hydrocephalus. Again, how would you suspect that patient has got hydrocephalus? Patient will get deterioration in his GCS. You repeat the scan, you will see dilated ventricles, and it is mostly because of the obstructive hydrocephalus, because blood is present in the system and it is obstructing the flow of the CSF. Immediately, patient would require EVD insertion, and EVD insertion has got certain other benefits because it removes the blood, it drains the blood from the interventricular system also. It appears to reduce the chances of vasospasm, and always remember that the hydrocephalus should not be decompressed suddenly, because again it has chances of causing further bleeding. So it has to be gradual drainage of the CSF to decompress the hydrocephalus. The time period, it appears mostly after the fourth day of event, and it has a risk of up to 21 days. The peak duration is 4 to 10 days. There is acute deterioration in the consciousness, or there may be new focal neurological deficit. Your patient may suddenly become drowsy or stops moving one side of the body. That means patient, and after the securing of aneurysm, patient has got vasospasm, there is cerebral ischemia, and it is produced by the spasmogenic substances which is generated by lysis of the clots. Sometimes delayed cerebral ischemia may not be attributed to vasospasm. There could be other reasons like microcirculation thrombosis, which still persists even after coiling of your aneurysm. That may also lead to delayed cerebral ischemia. So any neurological deterioration or focal neurological deficit and altered consciousness which persists for more than 1 hour and cannot be explained by other abnormalities, you have to contribute it to delayed cerebral ischemia. TCD, again a promising tool. You may early detect vasospasm by TCD by continuous monitoring. You can see there is increase in the peak velocities, and that means there is spasm of the vessel and you may have to intervene to further prevent it. Nimodipine, again, grade 1A recommendation. It has to be used in all the patients who come to you with aneurysmal SAH, and the dose is 60 milligram every 4th hourly. You may reduce the dose if your patient develops hypotension. Again, other measures to prevent vasospasm is to remove the blood clot if your patient is undergoing aneurysmal clipping, and our management, you should avoid hypovolemia and hypotension. So not hypervolemia, but euvolemia has to be maintained, hypovolemia has to be avoided, and you have to avoid hypotension after the coiling has been done. Nimodipine preferred agent, it has shown to improve outcome without reducing vasospasm. It is a neuroprotective agent. It works by reduction of calcium-dependent excitotoxicity. It diminishes platelet aggregation and dilatation of small arteries. Those you all know, it has to be started early and has to be continued for 21 days. Again, in cases of hypotension, you may have to reduce the dose, say to 30 milligram every 2 hourly or 30 milligram every 4th hourly, depending upon the clinical status of the patient. Triple H therapy, we all have been reading in the books. It is a history now, hypertension, hypervolemia, hemodilution. It is out now. Now a single H therapy, that is induced hypertension. And induction of hypertension by vasopressors may be required. Your patient has sudden neurological deterioration after coiling. You suspect that there is vasospasm, you may have to give noradrenaline to increase the blood pressure to maintain a certain MAP. Patient may require 110, 120, even up to 130 of MAP depending upon the response of your patients. So prophylactic hypervolemia is not effective in improving outcome. Euvolemia is the target for both prophylaxis and treatment. Hemodilution has no place until your patient has got polycythemia, where you would like to come down on the hematocrit. Induced hypertension, we've seen in practice that it is effective in reversing DCI. Patient becomes neurologically down, you give vasopressors, you increases the MAP, and you see the reversal of those neurological deficits. You give fluid boluses, sometimes you have to give colloids also to maintain a higher MAP, and then the vasopressor, and the target MAP is around 10 to 15% from baseline. Although it varies from patient to patient, it has to be based on your clinical monitoring. Increase blood pressure in a stepwise fashion, maintain a MAP for at least 48 to 72 hours before gradually weaning. Again, once you start weaning, you have to see the clinical status of the patient, the neurological status of the patient. If there is any deterioration, you may have to further increase the blood pressure and wait for a few days. So it is guided by your neurological function, neuromonitoring, and radiological evidence of improved perfusion. Titrate to the clinical effect, there is no one value that has to be targeted. It has to be individualized depending upon your patient's response. Again, if you are in a higher centers and you suspect your patient to have vasospasm, the patient should undergo DSA to confirm the diagnosis. Not only to confirm the diagnosis, you may intervene to reduce the vasospasm by giving intra-arterial vasodilators then and there itself. And the commonly used vasodilators are nimodipine infusion or milrinone. So, DSA followed by intra-arterial administration of nimodipine or milrinone has been seen to reduce the vasospasm and it prevents the DCI. Sometimes balloon angioplasty may have to be done for symptomatic vasospasm if the arteries which are involved are of larger size and which are refractory to your medical management. Other therapies, all endothelin receptor antagonists have been studied. Clazosentan not recommended, and it has got more complications like pulmonary edema or anemia. Sildenafil still not confirmed benefits, so not used much. Intrathecal thrombolysis, yes, meta-analysis has shown some benefit, but still there are no RCTs. But there are case reports that intrathecal thrombolysis has got some value. Now, is there any grading system available for cerebral vasospasm? We all know Fisher or the modified Fisher scale is available. where you see there are four grades. Grade 1 is thin SH without intraventricular extension. Grade 2 is thin SH with intraventricular involvement. Grade 3, you can see all thick blood in the cisterns but no intraventricular involvement, and grade 4 is thick SH with intraventricular involvement. So as the grading increases, the chances of developing vasospasm increases. So this is the monitoring guide. Patient is managed with medical management. You have to first optimize the blood pressure. You have to maintain the hypertension, and then you have got all those interventions which we have discussed to follow in the protocol. Hyponatremia, again, it's a common finding in any of the neurological patients. Even in SAH, if patient may have SIDH or cerebral salt wasting, you know how to differentiate these two depending upon the volume status, depending upon the urine sodium. It develops in 30% of patients, and the common days are 4 to 10 days after the admission. And obviously, you will have to detect whether it is SIDH or cerebral salt wasting because the treatment differs for the two. The other thing is seizures. The risk factor for developing seizures is if the patient has got thick clot, there is intracerebral involvement, the delayed cerebral infarction, or if the aneurysm involves the middle cerebral artery. Such patients are prone for infections, but again, universal prophylaxis still remains controversial, but still most of the neurologists or neurointervention, they give seizure prophylaxis to such patients, and but timely stoppage has to be done. The use of prophylactic anticonvulsants may be considered in an immediate post-hemorrhagic period, but 3-day treatment offers similar seizure prevention and better outcome than long-term therapy. So you have to stop it on time if your patient does not develop seizures after a certain days. Longer duration are required those who have got intracerebral involvement. Again, commonest antiepileptic used is levetiracetam 500 mg 12th hourly. It is most commonly used, and phenytoin is avoided in SAH and it is associated with worse outcome for two reasons. One, it has been seen to have long-term cognitive deficits in patients who have used phenytoin as anti-epileptic measure to prevent seizures. The other thing is, we all know phenytoin is an enzyme inducer and it reduces the availability of nimodipine, because we use nimodipine in all patients with SAH. So it's a neuroprotective agent. You give it with phenytoin, it induces the enzymes and it reduces the efficacy of the nimodipine. So it is avoided in patients with SAH. Cardiopulmonary complications, because it stimulates sympathetic system. You may get ECG abnormalities. There could be left ventricular dysfunction on echocardiography, elevation of troponin I, but that doesn't mean your patient has got ACS. These abnormalities, they revert after a certain days of the treatment. Coronary angiography, if done in such patients, is usually normal, and the complications, they reverse within a few weeks' time. Pulmonary edema, again, it is not very uncommon to see in such patients. That could be because of neurogenic or cardiogenic, depending upon the etiology. Again, a busy slide. There are certain complications which develop immediately, certain intracranial complications like increased intracranial hypertension, mechanical effects, early brain injury. These are the early complications because of the bleed, and there could be early systemic complications like systemic and parasympathetic overactivity leading to SARS, fever, pulmonary complications, neurogenic edema, pulmonary edema, and there could be delayed neurological complications like seizures, delayed cerebral infarction, obstructive hydrocephalus. So you have to have all these things in your mind while managing your patient with SAH. Take home message: approach these patients, urgent diagnosis must, whatever modality you use, it is immaterial, but CT is usually present everywhere, so the first modality of choice. Again, assessment of severity so that you can prognosticate the patient. You monitor such patients with high severity grade more closely, etiological workup, whether it is aneurysmal or non-aneurysmal. If it is aneurysmal SAH, early repair because it decreases rebleeding and it improves the outcome. It could be either surgical option or endovascular. Again, after securing the aneurysm, anticipate and treat complications we have already discussed, and anticipate a turbulent course for 2 to 3 weeks. If a patient goes down, doesn't mean your patient will not survive. There is a turbulent course and patient recover from very bad state to a better outcome. Thank you. I hope no questions. Thank you.
Thank you, ma'am.